Yes.
Professor, I'm going to take you to some guidelines for platelet transfusions. Can we have, please, BSHA 5031? When these come up, these are the British Committee for Standards in Haematology Working Party
Yes.
Blood Transfusion Task Force guidelines for platelet transfusions. And we can see under one the summary recommendations for the optimal transfusion support of patients likely to receive repeated platelet transfusion.
Yes.
And it says to determine policy for prophylactic platelet support and select the platelet count below which platelet transfusions will be used. And then if we go over, if we look on the right-hand column at the bottom there, indications for platelet transfusions, and we've got there bone marrow failure, and I'll read the detail of that in a moment. But are these guidelines that you were familiar with at the time that they came out?
Yes.
And we can see what it says under bone marrow failure. Platelet transfusions for patients who are bleeding. Platelet transfusions are established as effective treatment for patients with thrombocytopenic bleeding associated with bone marrow failure caused by disease. Cytotoxic therapy or irradiation. I think that's we need to go back a page, but that's right. Serious spontaneous hemorrhage due to thrombocytopenia alone is unlikely to occur at platelet counts above 10 to 20 times 10 to the 9 litre. Minor bleeding such as purpura and epistaxis may occur in platelet counts below 50 times 10 to the 9. And then it says about prophylactic platelet transfusions. They have been shown to decrease morbidity, though not mortality, in patients with thrombocytopenia due to bone marrow failure. And then the use of platelet transfusions to keep the platelet count above 10 times 10 to the 9 reduces the risk of hemorrhage as effectively as keeping it above any higher level. A recent study showed that a further reduction in the threshold for prophylactic platelet transfusions may be possible. However, if factors associated with bleeding in thrombocytopenic patients are present, such as fever and infection, concurrent coagulopathy, a rapid fall in platelet count, or if there are potential bleeding sites as a result of surgery, the use of prophylactic platelet transfusions might be considered to keep the platelet count above 20 times 10 to the 9. An optimal policy for prophylactic platelet transfusion has not been defined, and the threshold platelet count should be based on an audit of local clinical practice. So, first of all, did what's set out here accord with your understanding and your practice in 1990, just forgotten now, but 1992?
Not when I first came in 1976, because the precision of the delineation of the circumstances, as you find here, was less precise. But at the time, I think this document itself was published. I'm not on that page, but I think it was 1992.
Yes.
I would say, yes, our local practice was coincident with that pretty much exactly.
And does the reference in this document to that a recent study has showed that a further reduction in the threshold for prophylactic platelet transfusions may be possible, does that suggest that over the years the threshold for platelet transfusion on a prophylactic basis has changed?
Yes, it does suggest that, and it has changed. So both for platelet transfusion and for red cell transfusion, the threshold for the former platelets in grams per litre and for red cells in terms of the hemoglobin have fallen for two reasons. First of all, what you've discussed in part in what you've shown me is that you can give platelets at a lower threshold without increasing the bleeding in many circumstances, unless there's a complicating additional factors such as fever, which you've just discussed, in which case it may be safer to give the platelets at a higher level. And this has resulted in lots of good things, if you like, in the evolution over the last 20 years, which is the use of fewer platelets at a lower threshold, which is less risk for the patients because in some period, which is the basis of the whole of this inquiry, there was an infection risk, which, although very much reduced now, is not reduced to zero, so it is safer. It's safer without costing complications to the patient. It's safer because the fewer platelets decreases the likelihood of those complications I was talking about, which are firstly allergic responses and secondary refractoriness. And thirdly, these represent an expensive product to the system, and therefore it will reduce the cost of continuing to treat the patient just as safely. And fourthly, because blood and its products are extremely precious as freely donated, it reduces the overall consumption, which is good for the system and less demanding unnecessarily on the donor population.
Can I take you to another document now? NHBT 0010755, and just get your comments on a part in it. So this is the papers from a consensus conference
Yes.
on platelet transfusion from November 1997, abstracts, and if we go to page 4 of that document, we can see that it looks like you delivered a paper on trigger factors for prophylactic platelet transfusions, and it says there platelet transfusions in hematological malignancy have been traditionally administered when the platelet count falls below 20 times 10 to the 9 litre, thus reducing the hemorrhagic risk. And then missing out the next sentence, in our unit, shifting the threshold from 20 down to 15 times 10 to the 9 has shown a 20% overall reduction in platelet usage, but an instance of major hemorrhage changing from 12% to 10%. And then if we go down to the bottom, we can say, the last sentence there, if we in our own unit produced a 20% reduction in usage by shifting from a threshold of 15 down to 10 to the 9 litre, this would produce a saving in the cost of platelet transfusion of somewhere between £10,000 to £18,000 per month, whilst in addition lowering the infectious risk. So that's the first passage I wanted to show you. And the second, before I ask you the question, is on page... I haven't noted the page down, one moment. Page 21. This is in a part of the document entitled Poster Presentations. And P11, there's a survey of use of platelet transfusions in centres participating in the MRC leukemia trials. And we see that your name is there, the fourth one in. And if we go to the second paragraph, which says, in the planning of a proposal to study different regimes of prophylactic platelet transfusion support in a future MRC trial of AML in the elderly, hospitals participating in MRC leukemia trials were sent a questionnaire asking for details about their threshold for prophylactic platelet transfusions and if they used different thresholds for young and elderly patients. And then it sets out the different responses from the hospitals. Some of them were transfusing at less than 5, some less than 10, 15, 20, and so on. And at the bottom there, it says The last paragraph there says, this study shows that there is considerable variation in platelet transfusion practice amongst hospitals participating in MRC leukemia trials, providing justification for a large prospective randomised controlled trial of different prophylactic platelet transfusion regimes in acute leukemia. I just wanted to get your view on whether that, what's noted there, that there's a considerable variation in practice amongst hospitals participating in MRC leukemia trials, is reflected generally in your, to your knowledge, in practice outside those trials for platelet transfusion.
I'll try and make several points. First of all, I think, if I recollect, this is 1997, and I would say that there would be, I haven't got the data on me, I would speculate that there would be much less variation now than you see across the board in 1997, because people have taken into account those numbers of points which I've just enunciated, and paying more attention to guidelines and to safety, blood usage, and the associated economics. I think I think I would pretty much predict that the variability is much less. I'm not doing, as I told you, for some years, the adult leukemia unit at UCH, but I think the threshold is down to 10. We talked what would happen if we did it. And I think that threshold of 10, or even less in some instances, would be much more generalised across the centres in the country. The other thing that's happened, and in my view will continue to happen, is that since the 70s and 80s, as I said in the previous session, I think many more of these patients are being referred, quite rightly, into a fewer number of centres. So there are very few residual centres, I think, who would have thresholds like this away from the large centres, which would be very much along the national guidelines. So I would think, and I have not the data, that the outliers would be fewer. Now, the other thing that I was suggesting an hour ago is that I think the tendency to ultra-centralisation of complex medicine will now be exacerbated by the recent pandemic for a variety of obvious reasons. But in particular, to keep up the standards of the support for very complex care, you need staffing levels at a level of seniority in medicine and in nursing, which are increasingly more difficult to continue with on a widespread basis. So my overall answer is I think the variability has reduced significantly.
And the role of guidelines in reducing variability of practice. We are going to hear this afternoon from a witness who, in his statement, makes a comment that in relation to a particular set of guidelines, that none of the clinical colleagues he'd ever worked with had ever read those particular guidelines. What was did guidelines inform your practice, and from what you saw, your colleagues' practice in this area? Were they used, and were they helpful?
I think my answer would be much more positive than the one that you have just discussed. I think the community treating hematological malignancy is a smallish, very tight one. This is one of those diseases where there's been an enormous amount of national standardisation of the approach in terms of a quality basis, and that would include which drugs you would use at what point in AML, for instance, and also very largely include the supportive care and what you're talking about here now, the platelet support. So at those regional meetings that we mentioned, and at the blood transfusion centre itself locally, nowadays people would turn back and point out to people that, you know, you're giving prophylactic platelets at 25, and this hasn't been the national standard for 15 or 20 years. So I think they do pay attention very strongly to the guidelines, and the guideline production is a very strong element of the British Society for Haematology, which has guidelines produced in 4 different areas, and malignancy, transfusion, coagulation, and I think general haematology. It takes it very seriously, and will have sessions presenting those guidelines during the workup and when they're finished at the national meetings which we have. So I think there's a lot of attention to them. On the other hand, I don't think that people will have them on their desk in the ward, because much of ward care is still a kind of apprenticeship thing. So you're going round with the different groups of staff, and the consultant or the senior is constantly talking about why are we doing this, because it's against the guidelines or whatever it is. And I think there's much greater adherence than there ever was. So the guidelines, people respect them. They are exposed at the national meetings, and people will attend and listen extremely carefully. I think in training, you know, they're one of the things, it's not meant to be cynical, but pre an examination, the kind of thing that you're going to swat up on to make sure you've absolutely know where you are before you're vivid on how you would use platelets in acute leukemia in your MRC path examination or whatever it is. So I think, yes, they are respected. Some of it relates to the names on the paper. Mike Murphy, for instance, I know he's been a witness here, but he's a world authority on this, on platelet transfusion, and if he has something to say, people like me will listen extremely carefully. So yes, we take note of them.
And again, just expanding on the point that you make about how guidelines filter down to the local practice amongst the team. So as clinical director of the unit, how do your juniors, how do you ensure that those that you're training, those that are working with you, are transfusing to the same threshold as yourself, or is that not part of the unit ethos, or was it not part of the unit ethos and people could transfuse at where they thought was appropriate?
No, on the contrary, the unit ethos has always been unitary, so that although there may be often these days that there's a rotation of consultants looking after complex cases, because they have many other things to do, and it's very stressful to do it the whole year round. So you may have a year, you may have a month every 3 or 4 months in which you're looking after the inpatient AML patients. Now, that is based entirely on an in-house protocol deriving from the guidelines. So there is a house policy for platelet transfusion, which today, it wasn't always so, would be absolutely followed by the consultants, even if they were in charge in rotation. And all the junior staff would be constantly taught and retaught about the house policy of the levels for platelet transfusion. Now, there may be patients arising who give extra causes for concern, a patient with low platelets and complicating issues that we talked about, where you want to change the threshold, but that would, these days, be very little the individual, I don't like the term junior doctor's decision, it would be a unit policy. Now, today, to work on a specialist unit, you, in the one in UCH, which clearly is the one I've had the most experience with and the most closest to my heart, there are e-learning modules in the use of platelets, which any incoming junior member of staff will need to familiarise him or herself with and to pass before you can even work on the unit. So it goes down to that level.
And just before I leave the issue of platelet transfusion, do you recall whether ever in your practice you were provided with platelets from the blood bank and informed that they hadn't been tested for viral infections because they'd had to be provided in an emergency?
Yes, that was, of course, one of the questions in the questionnaire to me, and I have not seen that. And yes, do not remember discussing that specific at all.
I'm going to ask you some questions now about follow-up and viral testing. How long typically, you may not be able to give a typical length of time, but how long are patients followed up by your service?
Well, that would, first of all, it depends on the era. Secondly, it depends on the individual disease and the condition of the patient following the completion of treatment. So traditionally, a lymphoma or leukemia going into remission and staying in remission, when I say traditionally, up until maybe 10 years ago, and I'm really not totally conversing with the last 10 years, you would be seeing them at some interval period for 5 years. That interval period would extend as time went out, maybe 3 monthly in the first year or two, then 6 monthly for a couple of years, and then annually twice, something like that.
And was, as part of that follow-up process, once it was appreciated that people could have been infected as a result of their treatment, was testing part of that follow-up, testing for hepatitis C, hepatitis B, HIV?
I'll start with my remarks on hepatitis C, which again we specifically had a look at UCLH in 1995 when it was 3 or 4 years post the testing of donors, but we were notified by the transfusion service of 150 or so patients who had been treated before 1991 and therefore might have been infected with that virus before the regular tests came in. So we looked particularly at those who had abnormal liver function tests, and as you know from that publication that was sent to me, around a third of those did have evidence of the virus. But as far as I recollect, and those patients were then allocated either to the specialist haematologists whose patients they were, to the liver clinic at UCLH, or to a clinic run by the blood transfusion service. But I have to tell you in truth, I do not remember the follow-up on the other patients who were in that group but did not appear abnormal at that time of testing. So it was not systematic enough.
So those that, when you say were abnormal, do you mean that they had been tested and found to be positive for hepatitis C?
So there were two lots of abnormality. The first lot was pulled out because what we call the liver function test, the blood tests on how the liver was working, were abnormal. And within that group, I think a third or more did have evidence of the virus.
On testing for the virus?
Yes.
But by UCH?
Yes.
Yes. And you say that they were then referred back to their, if I can put it this way, their original clinicians who had been provided the treatment that may have infected them?
Yes, well, according to the paper, which is 27 years ago, with which you provided me, there was the first suggestion that they get sent back to the GP to sort out the level at which the information should be given to them, but I disagreed, as I recollect, with others, that we should be seeing them all, counselling them, and offering them expert follow-up in one of these three contexts. And as far as I remember, that's what we did. But
so your recollection is that their follow-up for their disease was at UCH rather than referring them to a centre where they lived, given that you had people presumably coming from all over the country?
Mostly at UCH. I cannot say that all of it was. We certainly offered the follow-up to all of them locally at UCLH and its liver clinic.
And do you know, can you recall whether there were any arrangements or testing done for HIV?
Well, so the tests, I think, for HIV on donors came in about October 1985. Now, as soon as those tests, which are usually used for donors for HIV and later for hepatitis C, became available, and much of the hepatitis C, as you will know, the testing was first researched and initiated by Richard Tedder at the Middlesex, who worked with us. So that once those tests were known, if you came presented as acute leukemia, getting those tests done before you started anything was one of the bank of tests that you had done initially. And then I do not recollect the intervals of that testing in treatment, but you could not go forward for a transplant at the end of that successful treatment without having that battery of viral tests done again. So that, and I think as soon as, and again, it's just memory, as soon as you went what looked like a long remission, you got the viral test done again. So you got them done during that treatment as a patient.
And you've said that you worked with Richard Tedder. What was the relationship between his virology lab and your unit?
So the Middlesex Hospital and the UCH Hospital, of course, amalgamated together to form UCLH within that new building. There were research laboratories of a variety of kind associated with both institutions at UCL. In other words, the real virology research in this area was done initially by Tedder, Middlesex Hospital and UCL, and then when the two hospitals came together, Tedder was our reference point, UCLH and UCL, if you see what I mean. So he was very innovative in this area and very dogmatic about the importance the rapid evolution of testing. And in the 80s and 90s, as he was getting more and more active and known in this area, that was the period in which this leukemia unit was starting to increase and have a lot of candidate patients who were having a lot of blood products. So we got on well with him. His virology clinical staff came to see for a consult our patients on the ward, and we collaborated with him in an academic approach wherever possible, because I thought he was a serious operator to be taken major notice of. So the real answer to your question is they did the clever work, and we provided these patients that we'd had referred to us because we could treat the leukemia, and these were patients getting exposed to a lot of blood products because you couldn't go ahead without doing that.
I'm going to ask you now some questions about your practice in relation to consenting patients to treatment. Is it right to understand your practice to have to look at it in two parts? That your practice pre the hospital transfusion committee's work on informed consent, which you think was about 1996. And then your practice post the work the Hospital Transfusion Committee did?
Yes. When I say I think it was 1996, there was no documentation. I didn't remember. And I have to say that I recently asked Professor Hannah Cohen, who was one of the major authors of it, and she said, well, we put it in as soon as the first shock report in 1996. So that's where I got that figure from. So before then, when a new leukemic presented, it would be my practice at the very beginning to spend an hour or more face-to-face with that patient and his or her family, whoever they wanted to be in the consultation, and to go through the pros and cons of, first of all, aggressive active treatment at all and what it might produce and at what risk, versus supportive and palliative care, in which you're saying, whatever we do will never really put you into a remission, and therefore you'll have to go through a lot of unpleasant treatment and we won't get a good result. But we not only said what we thought which group they needed to be in to get a good result, but it was a discussion of risk-reward basis. This is what we can do, and this is what might happen, and the results may be a high chance of a remission. Or even if we do this, this and this, and it takes 3 or 4 months of your life, we may still have only a 20% chance or whatever. There was that sort of discussion. And then there was a discussion about the components of treatment, which was when the leukemia unit was set up, first of all, you will have to be here, you the patient, for a lot of the time, and some of them were referred from a distance away, so please understand that. And then all the traditional stuff about how much you can have visiting, which on the whole was pretty liberal, but of course has been highlighted again, issues in the pandemic in the last 2 years. And then we talked about how many courses would be needed. So what's the total time frame to get a good result? And then we would talk about what the individual drugs do, what they might do if they're successful, and what the side effects may be. And then we would say, and you're going to need a lot of blood transfusion, both red cells and platelets. But in the early days before that watershed, or well before that watershed, there was no emphasis there, or little emphasis on viral infection as such. The blood product risks were more given out as those side effects of fever and allergic responses and becoming refractory to them, and bacterial sepsis, that there may be infection that comes to you very quickly because of a bacterial bug in the blood product, and truthfully little emphasis on the viral risk in the 70s and 80s.
And why do you think that was, given the growing knowledge of the viral risk from blood and blood components?
I think when I say little emphasis, I think it paralleled the tests coming through, so that you would certainly talk about the possibility of hepatitis B. You would see the time frame from the AIDS cases being reported in 82, 83, and people putting it together and getting the test done. It's about 3 years to 85. That risk to the leukemia patient, statistically, compared to the risk pre-testing to the haemophiliac who might have a pool from thousands of donors, was much smaller. So we altered the discussion of risk to the eras that the tests were available. But in truth, and I have discussed this with patients, there's sometimes a feeling that all this is terrible enough because some of these acute leukemias, you're ill over a weekend, and then on the Tuesday you're told you've got AML, so your life changes in an instant, and you've had this conversation for an hour, you've got to come. That, I don't think we actively underplayed the risk, but there's a kind of feeling there's enough to present these patients with, and if the Hep C risk is 1 in 13,000 or whatever for a donation which you found later, and there's some of the risk related to the interval window for the donor before the test became positive. In truth, it was sometimes a wish not to pile anything else on these poor people. One might say the consent was ill-informed in that I'd made a judgment that when they wanted the treatment, it was better to go ahead with it than go into too much statistical detail about that viral infection risk, and I'll hold up my hands to that. But that was a kind of clinical judgment of how do I deal with you, which is not giving information, but trying to make life just about bearable at the lowest possible moment. Does that make sense?
And then you, post the Hospital Transfusion Committee work being done, you say that your practice changed. So first of all, can you tell us what it was the Hospital Transfusion Committee did on informed consent and how that changed your practice?
Well, I think it has in general, and perhaps in particular, emphasised the importance of patient information and consent. They, at that time, after 1996, with the Hep B testing, the HIV testing and the Hep C testing, we could give a kind of a risk for each product donation. But again, in total, the leukemics were getting much less than the coagulation disorders. And hitherto, maybe most of these one-to-ones at the very beginning were done by me myself, and they went out to a team where we had a discussion as to how you would approach the patient and what you would say to them. So I think we paid more attention to the detail of the things that needed covered. It was a more formal conversation. Have we covered every single bit of this, rather than a chat from the leader of the unit, as it were. So it became more formal.
And that would include giving information about risks of viral infection from blood products, from blood components.
Again, I have not seen the documentation of the Transfusion Committee, but I think so.
And did you use patient information leaflets, and once the internet was more widely used, signposting patients to websites and so on for information?
Yes, that has intensified in the last 10 years, and is standard practice now. So in the 10 years before I retired clinically from the NHS to 2000 to 2011, that approach with internet guidelines, etc., was just coming in. But I was, again, doing strategic things and less directly involved with it myself than in previous years. But it's absolutely standard practice now. Is it right to understand from your statement that you didn't have a role on the Hospital Transfusion Committee? No, by that time, in 1996, I was trying to establish the allogeneic transplant program more fully, trying to work with the CEO and the chairman about the new hospital, I was more strategic in haematology as well as in the hospital in general. I was the medical director, and I think Dr. Patson and Dr. Machin and others did the work on the Transfusion Committee with the other clinical directors, the senior nurses, the senior laboratory staff, and they would send a report to me in my capacity as the medical director, but I would not regularly attend those meetings. And did the Transfusion Committee audit the practice of your unit? Again, without seeing the documentation, I can't confirm that 100%, but it did become from that committee the norm to be looking at the audit of blood product use, both from the haematology unit and some of the other big users of blood products. So I would say yes, but I cannot show you documentation. And can you recall what happened if the audit came back saying, well, we think there's been overuse or overtransfusion or findings of that sort? If, for instance, something came through from GI, gastrointestinal medicine or liver, about the use of blood products in biopsies that we thought was anomalous, my haematology colleagues on that committee, the HTC, would first of all, as far as I recollect, have some semi-formal discussion with the consultants on that unit and try and what we thought would be educate them as to a better practice. And if that failed, it might be a topic that would come through to me in my capacity as medical director, in which case I would, with the other consultants, go and talk to that unit. And if that failed, I'm just recollecting, and I've not got documentation, it's an item of sufficient importance about governance in practice that it might become might go to the board.
And did blood ordering schedules have a place in treatment on your unit? We've heard about it in other specialisms, and one can well understand how it might work with surgery and so on. But in terms of practice on your unit, was there any place for blood ordering schedules or mechanisms of that type?
Yes, I think we developed scheduling in relation to the need for prophylactic platelets, as we've been discussing, and the changing threshold for that. And also in the more stable patient in our unit and in others, the change in the threshold for red cells, where it's been quite clear over the last 20 to 25 years that for many patients, the top-up needs to be from a threat not to transfuse till the level is lower, and to aim the target of transfusion at a lower level than previously. So that was practice to schedule issues for that on the haematology unit as well as on the GI unit and other general medicine units. So yes.
And then final question from me. Were you, in fact, let's go to this document, NHBT 0083701. So this is a health circular from issued on the 11th of December 1998 in relation to the better blood transfusion from the NHS executive. Were you aware of the better blood transfusion initiative from the by the CMO?
In general, yes, but I don't specifically recollect this individual document.
But in general, you were aware that this was an initiative, and there was circulars and guidance and so on coming from the Department of Health,
yes,
in relation to that. And are you able to can you recall the extent to which it had an impact on practice?
Yes, I mean, first thing I can say is, in terms of the list of people for action by, would have come to me directly as a medical director of an NHS trust at that time in 1998. We would have discussions as part of our regular internal haematology unit discussions between the clinicians who particularly looked after the patients on the ward and the consultants in the laboratory, whether there was anything from a circular like this that we should be taking to the HTC. So yes, we did take notice of it.
And the points raised in it would have been discussed and actioned if necessary.
Yes.
So those were the questions that I had for Professor Goldstone. I'm conscious that call participants may want me to put more questions to Professor Goldstone. I don't know whether we could have a 10-minute break now and come back before lunch, or we should break early now and come back.
Well, I think we'll take a break now, and we'll come back at. You think 10 minutes?
Yeah. Yes. I think that should be sufficient.
Okay. Well, we'll come back at 8 minutes then to 1. The purpose of this, Professor, is to allow those who've been listening, who are representing groups of core participants, to work out whether their group would wish you to answer more questions, and if so, they'll pass the questions to Council, and she will ask you those questions. But we have to allow an opportunity for that to be done. That opportunity is now. I can't tell you how long you'll be kept after that away from your lunch, if you are at all. But it may be short, it may be longer, it depends how many questions there are. But we'll take a break now until 8 minutes to 1.
Thank you.